Good morning. It's my pleasure this morning to introduce Dr. Jared Routh. He's one of our second-year general cardiology fellows. Jared is originally from Burlington, Iowa, which I understand is in the southeast corner of Iowa. He did undergrad and medical school at Creighton University. He then did his residency and chief residency at the University of Iowa. He then worked as a hospitalist in Des Moines for a couple of years while his wife, Gina, who's a hospitalist in town, finished her residency training. They have a daughter, Eloise, who's almost 2, and they spend their free time as a family hiking, skiing, and biking, and at their lake home. Jared is looking to have a non-invasive career in cardiology with an emphasis on imaging. He hopes to stay in the Twin Cities, and we hope we can retain him here versus going back to Des Moines. So this morning for Grand Rounds, he's chosen a very interesting topic that I think is relevant to each of us and certainly to our patients. And I must say, I don't think, even though it is so relevant, I don't believe I've ever attended a talk on it. So I'm looking forward to your talk. Thanks, Jared.
Thank you, Dr. Harris. So hopefully everyone had a nice Thanksgiving weekend, and I appreciate you joining us here this morning. I'll be talking about trouble in thin air, and we'll be discussing primarily in-flight medical emergencies. If you've ever experienced an in-flight medical emergency or ever thought about it, as many of us have, it can be certainly an anxiety-provoking scenario. It's an unfamiliar clinical scenario in an unfamiliar environment. But you as a physician or a medical provider are at times a very important resource for the passengers on the plane and for the airline. So today we'll be describing the physiologic changes of travel. We'll identify the most common in-flight medical emergencies. We'll understand and talk about why responding to an in-flight medical emergency is challenging. We'll talk about the contents of the emergency medical kit and the onboard medical resources that are available. We'll talk about the legal protections afforded to Good Samaritans who choose to respond to medical emergencies. And then lastly, we'll assess a patient's cardiovascular fitness to fly and talk a little bit about some guidelines in terms of how long after a certain procedure can a patient fly, or after an MI, for instance. So I don't have anything to disclose this morning. And you might be thinking, as I did when I was putting this talk together, are you really going to talk about in-flight medical emergencies and anything related to air travel in the middle of a global pandemic? And you're absolutely right that since the COVID-19 pandemic began, there's been an unprecedented decline in air travel. Now, I'm not sure that that's necessarily the case anymore, watching the news this weekend with the number of people out and about and flying, but still, there are a lot less airplanes in the sky than there were 9 months ago. But hopefully the talk in maybe some ways serves as a harbinger for getting back to kind of our normal routine and vacation and flying and things like that. So first, I think we have to understand the scope of the topic to understand why this is an important topic. And in 2020, and then expected in 2021, there's nearly 4 billion annual commercial air passengers worldwide. And then in the United States, there's about 16.5 million flights annually. That's about 45,000 flights a day, carrying nearly 3 million people. And at peak times in the air over the continental United States, there can be as many as 5,400 flights in the air at any one time. The graph here shows a steady increase in the number of air travelers by about 7% over the course of the last 10 or so years. And couple this with an aging worldwide population, and I think you have a setup for an increase in in-flight medical emergencies. By some estimates, by 2030, 10 years from now, about 50% of the traveling public will be older than the age of 50. So we have a number of in-flight medical emergencies now, and I think they will continue to increase. So how many medical emergencies occur? There's different estimates, different series of data, and the numbers are probably an underestimate. There's no specific reporting system. There's no definition for what constitutes an in-flight medical emergency or what should be reported. But different series of data come up with different numbers. And they estimate about one we'll talk about this Peterson study a little bit more, but one in-flight medical emergency for every about 600 flights. Stated another way, 16 to 130 in-flight medical emergencies for every 1 million passengers, or some studies estimate about 44,000 in-flight medical emergencies worldwide. So now let's shift and talk about the epidemiology of in-flight medical emergencies. We'll talk about who respond, or the estimated in-flight medical emergencies, who responds, the most common emergencies, and then we'll talk a little bit about outcomes. This study was published in the New England Journal of Medicine in 2013 by Peterson and colleagues, and it probably represents the most comprehensive assessment of in-flight medical emergencies in the recent past. And they took data from 5 airlines over the course of 3 years, from 2008 to 2010. And their study represents about 10% of the total flight volume for that time period. So it's a pretty good representative sample. They looked at over 7 million flights, carrying about 750 million passengers. And again, this study identified about 1 in-flight medical emergency in every 600 flights, or 16 in-flight medical emergencies per 1 million passengers. And shifting gears then, who assists, who provides assistance in in-flight medical emergencies? You see here, physicians provide assistance in about 50% of cases. Flight attendants, just under 25%, or a quarter of respond to in-flight medical emergencies, and then nurses 20%. And I think a couple things from this. I think the nurses at 20%, that's probably an underestimate. It sounds like the way they structured the study and reported the data, that if a physician and a nurse, co-managed an in-flight medical emergency, the physician would probably get credit as the person responding. And if you've ever been on a flight when there's medical emergencies, you know that sometimes multiple people respond and multiple people assist with the emergency. What I think is also interesting here is that flight attendants are the sole managers or responders to about a quarter of in-flight medical emergencies. Historically, when air travel first started, flight attendants were actually nurses, and so there's some precedent for this, but I think it also tells us 2 things. Most in-flight medical emergencies are not serious, and that our flight attendants are well trained to handle a certain number of in-flight medical emergencies. So again, this study, 744 million patients. Just a flow chart here for how the patients were categorized in the study, and the outcomes of the patients. So looking at the patients and the study population as a whole, about 25% of them ended up being transported to the hospital. Of those total 15,000 in-flight medical emergencies, about 9% were admitted, and there was a mortality rate of about 0.3%. What are the most common chief complaints when it comes to in-flight medical emergencies? As I mentioned, most in-flight medical emergencies are not serious. And by far and away, syncope and pre-syncope as a chief complaint account for about 40% of in-flight medical emergencies in this series. And that ranges from things to vasovagal syncope. It could involve arrhythmia, it could involve hypoglycemia, intoxication, all sorts of different things. Remember, this is the chief complaint and not the final diagnosis. I'll point out here cardiac symptoms, because that's kind of what we'll be talking more about 8.3% in this study. And this is presenting chief complaint in terms of cardiac symptoms. So as you all know, patients with ACS, heart failure, arrhythmia, things like that can present a variety of different ways. They might present with syncope or nausea and vomiting. They might also present with respiratory symptoms. And then here we have kind of a hodgepodge of different medical conditions, all accounting for individually less than 5%, and in many cases less than 1 or 2%. Stroke, 2.2%, trauma, 3.4%. I was happy to learn that obstetric emergencies account for far less than 1% of medical emergencies, by some series less than 1/10 of 1%. So pretty uncommon, but you'll see later when we talk about flight diversions that they're actually one of the main reasons for diverting aircraft. So what about our diagnostic accuracy? You're responding to a medical emergency in a foreign environment, sort of a medically austere environment with limited resources, limited people around you. And so how good are we as medical providers in getting to the right answer? Well, in the Peterson study, there was about an 80% agreement between the presumptive on-flight diagnosis and the hospital diagnosis in that 25% of patients or so that were actually transported to the hospital. So we're pretty good, actually, and a lot better than I was expecting when I started to review these data. And then I think it's also reassuring to know that the patient's condition improved in about 60% of the in-flight medical emergencies surveyed prior to hospital arrival. And we talked about, only 25% of these patients even end up getting transported to the hospital, and going back, only about 35% even move from the airplane to an ambulance or anything like that. So, it's, again, just to reiterate, these medical emergencies, while some are serious, many are minor. I'm not going to talk about the management of individual conditions today. I think there's just too many to cover, and I have other material that I think is more interesting to talk about. But we will talk about a general approach to in-flight medical emergencies. But just remember, I presented the most common chief complaints, and within those chief complaints, there could be dozens of differential diagnoses. So that's important to keep in mind as well. Here in this slide, multivariate analysis looking at factors leading to aircraft diversion, which we'll talk about later in the talk, transport to the hospital, and then hospital admission. It's interesting that hospitalization rates differed by provider. Hospitalization rates and transport to the hospital were actually highest for EMS providers responding, and then second highest with physicians responding. The conditions most associated with transport to the hospital and then eventual hospitalization in this study were stroke, respiratory symptoms, and cardiac symptoms. In other series, obstetric emergencies are also very, very common. And like I said, we'll come back to the analysis of aircraft diversion a bit later in the talk. So now we sort of identified the most common medical emergencies, who responds to those emergencies. And now let's talk about the cabin environment. What preconditioning occurs? What makes this a challenging environment? And how does this environment affect our patients? So we'll talk about the pre-flight environment, which I think is often ignored in this topic. We'll talk about pressurization of the cabin and how it relates to oxygenation. We'll talk about air quality, and then we'll discuss the physical constraints of responding to a medical emergency on an aircraft. So as many of you maybe have personally experienced, or family members that are, have a lot of anxiety and stress as it relates to flying. I know personally flying is not always easy, and sometimes it can certainly be very stressful. And so we have to take that into account. We also have to think about the increased activity physically and mentally and emotionally that our patients or passengers undergo. Take your average patient, I think, whether it's someone with cardiovascular disease or someone that's healthy, that's 65 years old, and think about how much activity that on average those patients probably do in a day or in any given time period. And if you think about air travel and what that involves, it involves packing, it involves loading a suitcase, traveling to the airport, parking your car, taking everything in and checking in, then moving through security. And we all know that security measures are more enhanced these days. You're waiting longer, you're standing longer. And then it might involve a long walk to the gate, standing up again, waiting to board the flight, and then making their way down a pretty cramped flight or a cramped airplane. And so it's easy to see that for a lot of our patients, and perhaps the majority of our patients, this might be the most physical activity they've done in a long time or will do. And so we have to take into account the preconditioning that occurs in our patients before they ever step foot on the airplane. So what about the physiology of air travel? How does our body respond to the changes that occur, and what changes occur on the airplane? So the barometric pressure at sea level is about 760 millimeters of mercury, and at altitude on an aircraft with pressurization of the cabin drops to about 565 millimeters of mercury. And as the pressure drops, we know that the partial pressure of oxygen also drops. And so you might recall that this is Dalton's law from high school or college physics. So the cabin is typically pressurized to about 5,000 to 8,000 feet. Commercial airliners fly at somewhere between 30 and 40,000 feet. That's obviously not compatible with life. So the cabin is pressurized. And if we look at the partial pressure of oxygen at a simulated altitude of 5,000 to 8,000 feet, we see here, taking you back to the old oxyhemoglobin dissociation curve, that PaO2 drops from about 95% to about 60% or so. Stated another way, oxygen saturation drops in healthy patients from 97% or so to somewhere in the neighborhood of 90 to 93%. Now for you or I, presuming we don't have any cardiopulmonary conditions, this is an unremarkable drop. It's not associated typically with any symptoms. But if we think about patients with cardiopulmonary disease, they may be at increased risk for hypobaric hypoxia. The reason? In URI, the drop from near 100% or 100 millimeters of mercury PaO2 to 60 or 65, that occurs on the flat part of the oxyhemoglobin dissociation curve. However, in our patients with pre-existing conditions and cardiopulmonary disease, patients that might be on oxygen at baseline or might be at risk for hypoxia, the curve is shifted. And so the drop in PaO2 might find those patients on the steeper portion of the oxyhemoglobin dissociation curve, placing them at significant risk for hypobaric hypoxia. What other changes occur in response to the change in pressure in the cabin? Well, according to Boyle's law, there's an inverse relationship between pressure and volume. So as the cabin pressure drops, as the plane ascends, volume can expand up to 30%. We've all experienced this, right? It's discomfort in our inner ear, it's popping of our ears, it might be manifest as gastrointestinal discomfort. But in patients with pre-existing conditions, it might be more detrimental to them. It might also be detrimental to patients who have had recent surgery, or patients with feeding tubes and catheters, or patients at risk for spontaneous pneumothorax. So this also contributes to the preconditioning of patients on the aircraft. What about the air quality on the cabin, in the cabin? So I mentioned that the cabin is pressurized to 5,000 to 8,000 feet. That's what's mandated by the FAA and other organizations. In reality, and at certain times on the airplane, the cabin might actually be pressurized to a higher altitude temporarily, but what's regulated is no more than 8,000 feet. And the way that's done is the air in the cabin is cycled through the engine compartment, leading to pressurization. The other effect of this is it leads to significant dehumidification of the air. We've all been on airplanes and noted that the air is really, really dry. And this can lead to dehydration. It can also lead to exacerbation of reactive airway disease in our patients. So something else to keep in mind. And lastly, the physical space. As you know, if you've traveled recently or within the last year, airplanes are tight, cramped places, and they're getting tighter. So in 2000, the average seat width was about 18.5 inches. Now it's 17 inches. And there are some airlines like United Airlines way back there in economy that have seats that are as narrow as 16.1 inches. And so it's the seat width, but it's also then how many seats are crammed onto the airplane. And airlines are doing that to move more people at once and to increase their margins. I had no idea this was the case, but the Airbus A380 is the double-decker plane. It's the largest commercial passenger plane in production or in existence. And when they set that plane up, if they set that up for just economy class only, it can hold almost 900 passengers, 868 passengers. So being on a plane with 350 people, transatlantic flight is a lot of people, but I can't even imagine being on a flight with nearly 900 people. So this simply makes things more difficult for our patients. It makes, especially as the passengers and patients with the obesity epidemic, it makes that a little bit more difficult. It makes getting to and from their seat more difficult, and it physically makes responding to an in-flight medical emergency more difficult. You have to get that person out of their seat and to an area where you can examine them and talk to them. And oftentimes that's difficult because airlines have taken some of those common areas away and replaced them with seats. In addition, planes are noisy and there's a lot of vibration. This can make communicating with passengers more difficult. It can make auscultation of the heart or taking a pulse more difficult, taking a blood pressure more difficult. So just the cabin environment itself makes responding to an in-flight medical emergency a little bit more onerous. So now let's shift to sort of the main thrust of the talk, which is recommendations for responding to an in-flight medical emergency. And I'm hoping that after this part of the talk, you feel a little bit more comfortable, maybe a little bit more in command of the situation perhaps, and feel more ready to respond to an in-flight medical emergency if you're ever put in this position. Your role in responding as a medical provider is to serve as a team member and assist the crew, the passenger, the captain, and the other passengers on the plane. And it's not to take control. So you're a member of a team, and your role as simply stated as I could put it, is to gather information, assess the passenger, aid in communication with the flight crew and the ground-based support, provide an assessment and a recommendation, and then administer any medications or perhaps perform any procedures that are within the scope of your expertise. We'll talk first about the resources that are available to you in responding to an in-flight medical emergency. We'll talk about some of these individually, but I think the point is that there are actually a host of resources that are available to you beyond just the emergency medical kit, which we'll talk about. So flight attendants, as I mentioned, they in many series handle about 25% of in-flight medical emergencies by themselves. Flight attendants are trained in first aid, they're trained in CPR, they're trained in the use of the defibrillator, and they're very aware of the procedures on the aircraft and of the airline, and they know the contents of the emergency medical kit, they know where to find it, and they know where things are located within the emergency medical kit. Most airlines also contract with ground-based medical consultative services, which we'll talk about later. There's the onboard medical kit. We'll discuss what's in it. And then all aircraft have at least one automated external defibrillator. This was mandated by the FAA back in 1998 and then implemented by 2001. And flight attendants are trained, as I mentioned, in the use of the defibrillator. And then other passengers can be a significant resource, whether it's other medical personnel or whether it is what the passengers are carrying with them. We'll talk about things that are noticeably absent from the emergency medical kit. Some medications, glucometers are actually not included regularly in the medical kit. And so these things can oftentimes be obtained from your fellow passengers. So what's included in the kit? So on the left-hand side of the screen is what's required to be in the standard emergency medical kit. On the right-hand side is what's in the enhanced emergency medical kit. Not required by airlines, but most, or I shouldn't say most, but the majority of airlines carry at least some contents involved here in the enhanced kit. Interestingly, a study of about 400 health professionals identified that 50% of medical providers really had no idea what was in an emergency medical kit on board an airplane. So hopefully after this slide, you won't be in that that 50% anymore. So over here, you've got a variety of medical equipment. You have oropharyngeal airways and other types of airways. You have IV start kits. You have syringes, needles. You have a stethoscope, a blood pressure cuff. You have tourniquets and scissors and things like that that can be used for response to trauma. And then in terms of medications, you have non-narcotic analgesia. You have antihistamines in both an injectable and an oral form. There's atropine, there's aspirin, there's bronchodilators. You have at least one ampule of D50. Excuse me, there's epinephrine in 2 dilutions, 1 to 1,000, which is used intramuscularly in response to anaphylaxis. And then a 1 to 10,000 dilution, which you're familiar with for ACLS and cardiac arrest. Interestingly, IV lidocaine is included in these kits, and that's probably a leftover from the old ACLS guidelines, which included lidocaine in the ACLS algorithm. There's also nitroglycerin, and there's about 500 cc's of normal saline. In addition to this, there's oxygen. There's plenty of oxygen on board the plane, so you don't have to worry about running out, but the rate that the oxygen can be administered is limited to about 4 liters by face mask. So it's not a fast rate. As I mentioned, many airlines choose to carry a more enhanced medical kit. And with that, you have some additional equipment here. Sometimes a glucometer is included. Additionally, you'll note that a pulse oximeter is noticeably absent over here as well. Oftentimes with the enhanced kit, most airlines are carrying a pulse oximeter these days. But still, you're not going to have everything at your disposal that probably you would like. In terms of other medications included in the enhanced kit, this is not necessarily standard, but just sort of an example of the different medications that might be included. So it includes benzodiazepines, which can be used for seizures, potentially for sedation of your fellow passenger, and as an anxiolytic. It includes steroids, it includes antiemetics, it includes potentially AV nodal blocking agents. It also includes opioid analgesics, and it includes opioid antagonists in the form of intranasal naloxone. Most of these medications are available in an intramuscular formulation, so an IV doesn't necessarily have to be placed to use them. But obviously the ACLS, 1 to 10,000 dilution of epinephrine is used intravenously. What does the kit look like? Here's an example of Air Canada's medical kit. It's nicely organized. It's well laid out. I don't think you'd have any problem locating the drug or the piece of equipment that you wanted within this kit. Here's Lufthansa's medical kit. Again, I think it looks very comprehensive, but you're going to have to open those packages up and you're going to have to know what's where. And so this is where the flight attendants really come in handy in helping to locate these things. We talked about the advantage of having ground-based medical consultative services. Is an example of 2 companies which are based in the United States, MedLink by MedAir, which is out of Phoenix, Banner Health University, and then StatMD, which is out of the University of Pittsburgh. Both of these companies are staffed with board-certified emergency medical physicians that are actually a part of the faculty at both of those institutions. And as a part of their work rotation, they rotate through the call center. And they provide emergency telemedicine services for aircraft. Most airlines contract with one of these organizations. And these 2 organizations are affiliated with over 150 international airlines. The call centers, they're staffed with emergency medicine physicians, APPs, and nurses, all trained in responding to in-flight medical emergencies. Looking at MedLink by MedAir specifically, they respond to about 100 calls a day, and in 2018 took about 42,000 calls from airplanes. They can communicate in over 140 languages with the use of translators. And the advantage is a couple things. Number one, they're emergency medicine physicians. So they're trained in approaching and taking care of a completely undifferentiated patient. I think, and that's for most other medical personnel. You don't very often encounter a completely undifferentiated patient in an emergency setting. Additionally, they're trained in the airline's protocols. They're aware of the medical equipment that's available, and they're aware of the other resources that are available. They know where things are within the medical kit, and they can provide recommendations and to help you manage the patient. Oftentimes, they will already be aware of the emergency before you're asked to respond to the emergency. And oftentimes, the call for a medical volunteer is prompted by these consultative physicians on the ground. Additionally, if the decision is made to divert the airplane, they're very, very helpful in determining whether diversion should happen, and then if diversion is deemed necessary, deciding where to divert the airplane to. And that brings us to flight diversion, which I think is something that we all wonder about, and is sort of that thing in the back of our mind that, if you're responding to a medical emergency, well, do you need to land the plane? Is there a benefit to doing that? Is there a benefit to getting that person in a hospital sooner? And so about 2 to 7% of in-flight medical emergencies result in a diversion. It's important to remember that the decision to divert the airplane is solely the captain's and no one else's. You as a medical provider make a recommendation. The ground-based medical consultative services make a recommendation as well. But the decision to divert is 100% the captain's. If we look at rates of diversion, again, those differ just like hospitalization rates based on who responds to the emergency. With emergency EMS providers having the highest rate, followed closely by physicians. The most common causes leading to diversion of the aircraft include cardiac arrest, obstetrical emergencies, cardiac symptoms in general, and stroke. But it's interesting that only 42% of in-flight cardiac arrests actually result in aircraft diversion. And we'll talk a little bit about the timing that's involved in diverting an aircraft. But really, diversion is only recommended if you are able to achieve ROSC in that arrest situation. Interestingly, the decision not to divert the aircraft is the most common cause of litigation against the airline in in-flight medical emergencies. We'll talk about legal ramifications later, but if you recommend diversion and the pilot and the airline choose not to divert the aircraft, you're not held liable in that situation. But it's a very complex decision that takes into account a number of different factors that have nothing to do with the medical emergency that's happening on board. So the pilot and the airline have to think about the weather. They have to think about the fuel load. They have to think about whether the airplane that they're flying can even land at a certain airport, and then whether there are the services available to service the aircraft and take back off. You have to think about what medical resources are available at the closest airport, and that's where the ground-based consultative services help. And then you have to think about the time that it takes. So by some estimates, from the time a captain decides to divert the aircraft to the time when EMS personnel are boarding the aircraft, that can take sometimes 30 to 45 minutes. So you're going to have to continue to manage that patient for a significant amount of time. And it's not as easy of a decision as just saying, yep, land the plane, and then 10 minutes later you're on the ground and EMS are have the patient on a stretcher and they're getting wheeled off the airplane. The cost is also significant. The estimates are all over the place here, but somewhere in the neighborhood of $20,000 to nearly $900,000 at the cost of the airline to divert the aircraft. A study in 1997 by the Air Transport Association showed a 70% reduction in aircraft diversions in airlines that use ground-based medical consultative services. So number one, those services probably pay for themselves. And number two, you shouldn't be surprised or offended, I think, if you recommend diversion or talk about the diversion and the ground-based folks or the pilot says, no, absolutely not. We're just going to continue on to our destination. So to recap the medical volunteer role, this is adapted from a couple different resources, but I think best you should decide if you're in proper condition to respond. We'll talk a little bit more about that. Introduce yourself, state your medical qualifications, ask the patient if it's okay for you to treat them. obtain the emergency medical kit from the flight attendants, quickly gather information, perform a limited physical exam, take vital signs, identify any high-risk features, and then make sure you're communicating well and identifying and informing the flight crew of your impression. Additionally, you want to communicate with the ground-based folks, you want to communicate with the flight crew and provide those recommendations that you have. Then administer any treatment or medication within the scope of your practice. And then I think this is an important recommendation. Make sure that you document the encounter just as you would in the clinic. The airline probably will have you fill out some type of form, but I think it's important and it's recommended that you keep a copy of that as well. So just snap a picture of it on your phone so you have something for your own documentation. And then remember that patient privacy rights remain unchanged, just as they would if you were taking care of someone in the clinic. So now that we've talked about how to respond to an in-flight medical emergency, let's talk about the legal ramifications of doing so. And I think that this is kind of an interesting topic, and this is sparks a lot of question from medical providers in these situations. And it was actually cited as the leading reason for reluctance on behalf of medical providers to respond to in-flight medical emergencies. So what protections do you have? In the United States, in 1998, the Aviation Medical Assistance Act was passed. And this, in short, essentially granted Good Samaritan status to any medical provider responding to an in-flight medical emergency. And this applies to domestic flights within the United States. It probably applies to all US airlines traveling internationally and from any flight that originated in the United States. The other things that it does, it says that you don't have to be asked by the airline to provide assistance. If you see an emergency, you're able to respond to it before being asked. And there was some ambiguity in previous law about that. Thankfully, it doesn't give you any legal authority over the plane. And as I mentioned, you can't be held liable if the pilot or the airline doesn't follow your recommendations. Furthermore, you cannot be held liable if the airline fails to provide the necessary equipment or working equipment, and the patient is harmed as a result. It also mandated medical kits and the training of flight attendants. And this is the law that mandated AEDs on all flights, which was implemented in 2001. What it doesn't do is it doesn't absolve you of legal duty in areas of gross misconduct and negligence. And we'll talk a little bit about that later. It also protects the airlines from liability if you as the medical provider are negligent in some way in responding to the emergency. So next what we'll do is we'll just go through some commonly asked questions as they relate to your legal obligations and the legal ramifications of responding to an in-flight medical emergency. I'm not an attorney, and so this isn't legal advice, but this is what I sort of compiled from physicians who are experts in this area, and then from attorneys and legal scholars who have written on the topic. So am I legally obligated to respond to an in-flight medical emergency? Interestingly, in the US, in the UK, and Canada, no, you have no legal obligation as a medical provider to respond to a medical emergency. If you want to sit quietly in your seat, you can certainly do so. However, in certain countries in Europe, Australia, and across the world, there is a legal obligation to respond to medical emergencies, and hopefully, moral and professional obligations will override. Do I need to provide my credentials? This is a commonly asked question. So this is technically unclear. The AMAA says that if there's a medical emergency on board and a flight attendant asks for a medical provider to respond, and you push the call button and say, I'm a physician, how can I help? The flight attendant is able to take your word in good faith and allow you to respond to the emergency. But some airlines recommend that the flight attendants do ask for medical credentials. So you shouldn't be surprised or offended in some way if you say that you're a physician and the flight attendant says, show me some sort of proof. And I think with today's technology, this is easy to do. You can carry a digital copy on your cell phone of your medical license, medical diploma, or board certification very, very easily. What about protections on international flights? So the AMA provides protection on US airlines and domestic flights. But what about international flights? So this actually gets a little bit tricky. Travel obfuscates borders. And so the law of the country that the incident occurs in could potentially apply. The law from where the flight originated could apply, or the law where the flight lands could apply. Flights outside of the United States and just flight law in general is governed by a lot of complex agreements. But I think from the reading that I did and the resources that I reviewed, most countries have a precedent for Good Samaritan provisions in protecting you. So you're on vacation. What if you've had a few cocktails before the flight took off or on the flight, and the call goes out for a medical provider to respond? Should you decline to provide assistance? This gets even trickier if no one else puts their hand up before you and you're potentially the only medical personnel on board. So the question isn't so much alcohol, but impairment. And so we can be impaired by many different things: sleeping pills that you've taken on the flight, anxiolytics, jet lag, fatigue, all sorts of things. And so I think the thing to remember here is that Good Samaritan laws don't apply in cases of gross negligence and willful misconduct. And it's not so much, well, it is how your perception of impairment, but also how other passengers might perceive you if they've seen you drinking or anything like that on the flight beforehand. And it's important to remember that, even though this is a medically austere environment, good intention in no way protects you from negligence or willful misconduct. So does the AMA provide full unrestricted protection? So no, it protects you as the Good Samaritan from liability in settings of competency and within the scope of his or her training. So what does this mean? I think in short, it means no heroics. Certainly the standard of care is different on an airplane than it would be in your office. But if you've never performed a needle decompression of a pneumothorax, then that psychiatrist probably should just keep their seat potentially and manage the patient in other ways. And this is commonly asked: can I accept any money or upgrades? What about vouchers for a future flight as a thanks from the airline for responding? The AMA or AMAA specifically states that you're a Good Samaritan and there's no monetary compensation. The non-monetary compensation is a little bit of a gray area, and different papers that I reviewed, the experts sort of are conflicted here. I think it's probably safest if you don't. But again, there's not a right or wrong answer here. So has a physician ever been successfully sued for assisting in an in-flight medical emergency? So there's little case law precedent to support successful lawsuits against physicians who are not negligent or do not engage in any sort of misconduct. But as a Good Samaritan, you have to remember that those laws don't necessarily protect you from a lawsuit being filed against you. So there is the potential for you to be sued, whether that lawsuit carries forward and probably would be later dismissed, but that's something to consider. And then lastly, kind of a fun one: can I bill for my services? So again, remember, monetary compensation negates the Good Samaritan laws. But in 1997, a California psychiatrist was on a British Airways flight. He responded to an in-flight medical emergency. About 2 weeks later, he sent British Airlines a bill for $750 for services rendered. You might not be surprised to hear he lost in court. So probably best just to leave money out of it. And so for the last part of the talk, we'll discuss the pre-flight assessment of cardiovascular disease and cardiovascular patients. We'll talk about contraindications to air travel. We'll talk about air travel after specific procedures and specific cardiovascular medical conditions. And then we'll talk about what should make up a pre-flight evaluation. So this is from the Aerospace Medical Association, and it outlines Cardiovascular contraindications to air travel. There's some variation here in the first two recommendations, talking about air travel after MI, and we'll get to that a little bit later. But what they say is that after an uncomplicated MI, you shouldn't travel for 2 to 3 weeks. After a complicated MI, 6 weeks. Patients who have unstable angina, decompensated heart failure, uncontrolled hypertension, significant untreated valvular disease, those patients shouldn't fly. They recommend waiting at least 10 to 14 days after CABG. They recommend waiting 2 weeks after a stroke. Looking first at patients with coronary artery disease and recent ACS. So this is a small study, but kind of an interesting study. They took 18 patients, 8 of which had coronary artery disease, and they assessed myocardial blood flow at sea level and at altitude, and then with rest and stress. And what they found was that altitude at rest really had no effect on myocardial blood flow and coronary reserve. However, when they added exercise into the equation, there was a decrease in exercise-induced coronary flow reserve in patients with coronary artery disease, which might suggest that some of the compensatory mechanisms that we earlier discussed might be exhausted in these patients. So in patients with stable coronary artery disease, in patients with stable angina, in patients that have had a prior MI, there's really no contraindication to air travel. The key word, though, is stable. In patients with an uncomplicated MI recently, the experts in different literature recommend waiting about 2 weeks. And in patients with complicated MI, there's a little bit more variation here, but a lot of the experts in the papers I reviewed recommend waiting about 2 weeks after the patient's medically stable. If you're still unsure whether your patient is fit to fly, you can consider a symptom-limited exercise stress test. And I'll add that most of the recommendations here are expert-based. So I scoured the guidelines for firm recommendations on travel, and the ACC/AHA guidelines actually have made no comment about air travel since the 2004 update to the 1999 STEMI guidelines. And we know that we have newer guidelines in terms of STEMIs since that time. Additionally, a lot of these studies have occurred over the last 3 or 4 decades or so, and they're typically small studies. And so some of the recommendations differ, but I think what's presented here is pretty uniform across those different sources. But I think the British Medical Journal Heart did a really nice job in outlining things a little bit further in their Fitness to Fly report from 2010. And they list or kind of lump patients into 3 categories: very low-risk patients, low-risk patients, and high-risk patients. Very low-risk patients include patients that are less than 65 years old, where it's their first event, where they've been successfully reperfused, their EF is largely preserved, and their event was by all means uncomplicated. And they actually go as far to say that if a patient falls into that group, they might be able to safely travel in 3 days. And I think this is particularly important when you have a patient who's maybe been traveling and visiting family here in Minnesota, they have an MI, and all they want to do is get home. The low-risk patients, they say 10 days, and high risk, of course, again, contraindicated. So what about heart failure patients? So there have been a few studies, again, largely small studies with simulated altitude environments, but this study took about 70 patients with class 2 or 3 heart failure and an EF less than 40%. They subjected them for an hour to a simulated environment. None of the patients had a worsening of symptoms. In a similar abstract by the same group, they took patients with NYHA class 3 or 4 symptoms, subjected them to the same environment. Again, no symptoms. The ideal cabin environment study took about 75 patients with NYHA class 2 symptoms, and they actually simulated a longer 7-hour flight. And in general, this was, again, well tolerated. So I think this is to say that, yes, there are changes within the cabin environment that we talked about, but they're relatively well tolerated in stable patients. So patients with stable chronic heart failure, there's really no contraindication to air travel. Things to think about, though, are your patients with NYHA class 3 or 4 symptoms. And in those patients with a baseline SpO2 less than 92%, you might consider supplemental oxygen, and you might consider recommending airport assistance for those patients. There's little data on recent exacerbation, but some studies, few experts suggest waiting about 6 weeks, but this is probably best undertaken on a case-by-case basis. Patients with severe decompensated heart failure or really any type of decompensation, air travel is contraindicated. What about patients with cardiac devices, pacemakers, ICDs? I'm sure that's a common question that many of us get in our clinic. This study here from 2003 looked at 350 patients with pacemakers and ICDs, and there was not found to be any interaction or changes made to the pacemaker based on the airport metal detectors or the imaging that's done in terms of security or any in-flight interference. The airport medical detectors are rarely set off by these devices, but patients should carry their device cards with them. If patients are particularly worried, that they can request a hand search by the security personnel. And what about any in-flight interference? The only thing that there's case reports on is in some patients whose pacemakers have a rate responsive feature. Sometimes the vibration on the plane can actually cause some issues with this. But other than that, there's not a lot of data to support interference between cardiac devices and air travel in the airplane. And what about DVT and PE? I think that this is well within the scope of a cardiologist and general medical providers to make a recommendation to our patients in this regard. And so what they say is that patients that are at low risk for VTE should take precautionary measures like avoiding restrictive clothing, staying well hydrated, and doing frequent calf muscle contraction. For patients at higher risk, you can consider graduated compression stockings, or you can consider a single dose of low molecular weight heparin. They recommend against using aspirin in terms of prophylaxis for VTE. So what about travel after cardiac procedures? Again, these recommendations are largely expert-based, but what we have is that after elective coronary angiography without PCI, it's probably very safe for that patient to travel even the very next day if everything was completely uncomplicated. In patients who underwent uncomplicated elective PCI, experts would suggest that it's probably safe to travel in about 2 or 3 days, give or take. Patients after CABG can probably safely travel in about 10 to 14 days. And this is essentially the time it takes for any intrathoracic air to resorb within the chest cavity. Patients with pacemaker who have recently received a pacemaker or ICD generally should wait 1 to 2 days to travel, except if the procedure was complicated by any degree of pneumothorax. And if that's the case, they should wait at least 2 weeks. And that's, again, time for that air to resorb. So as we close, we'll just talk about what should make up your pre-flight evaluation. I think it's probably rare that a patient comes to your clinic specifically for this reason. And it's more so they've come for a routine visit, and in the last 2 minutes as you're walking out the door, they say, hey, I'm going to Florida next week, can I travel? Or as you're walking out the door after the procedure that you've just done, they say, hey, I want to go to Florida for Thanksgiving or for vacation. I have a winter home in Arizona. How soon can I get down there? And so I think we've covered that, but what else should be involved in that evaluation? Fortunately, it's pretty quick, and it's not too onerous. So what we talked about in terms of absolute contraindications to air travel really are decompensated patients. So assess your patients for signs and symptoms of decompensation. Evaluate whether they've underwent any recent surgeries or have any procedures upcoming. Assess for the presence of cardiac devices. Take their vital signs, including a resting SpO2. You should think about recommending and prescribing oxygen if your patient needs oxygen at rest, if their resting PaO2 is less than 70 millimeters of mercury, or their SpO2 is less than 92%. You should think about recommending oxygen if they have NYHA class 3 or 4 symptoms, as we talked about. If you're unsure or you don't know whether your patient should have oxygen, you can consider a hypoxia altitude simulation test or a 50-meter walk, which we'll cover on the next slide. And then I think it's within the scope to assess your patient's need for some sort of DVT or VTE prophylaxis. So the hypoxia altitude simulation test is not offered at a lot of institutions, but what it is it essentially simulates the cabin environment in terms of oxygenation by mixing nitrogen with oxygen. And with the test, if your patient's PaO2 drops below 50 or their SpO2 below 85, you should think about recommending oxygen. A little bit easier than this is a simple 50-meter walk test, which is where you have your patient walk 50 meters, and if they're significantly dyspneic or have difficulty doing that, then think about prescribing oxygen. What other recommendations do I have that you can make to your patients? So recommend that your patients bring their medications with them and that they have their medications in their carry-on luggage. It's not a bad idea to give your patient a copy of their most recent ECG and make sure they have any device cards that are relevant. I think one thing that we can do as providers is recommend that the patient contact the airline to request accommodations. So this can help limit ambulation and physical activity on the day of travel and can really help our patients in that pre-flight and post-flight area. Think about supplemental oxygen. And in our patients with significant comorbidities traveling internationally, think about recommending medical evacuation insurance, which is typically relatively cheap. So with that, I'll conclude and just cover a few key points that I really hope you glean from my talk today. First, the cabin environment results in significant physiologic changes, but in stable patients, these changes are generally well tolerated. Remember, most in-flight medical emergencies are minor, but you are now aware of the most common chief complaints. As a medical provider, you're now more familiar with the contents of the emergency medical kit and that you should request it. You now know that airlines contract with ground-based medical support and that you as a medical provider are generally legally protected from any liability based on Good Samaritan provisions. So with that, I'll conclude and take any questions that might be coming across the chat. Thank you.
No questions as of right now.
Dr. Hurl.
I'm going. Great talk, very comprehensive. I was just questioning with the medical kit, do they include a magnet?
No, I don't think so. Yeah, it's a great question. I think everyone heard that, but Dr. Hurl asked if a magnet's included in the kit. And no, from what I reviewed, I didn't find anything that specifically said there wasn't a magnet, but on all the different lists I reviewed from different airlines and from the FFA, I don't think that that's commonly included, but it's a really good point. Yes?
What are the recommendations as far as pregnancy?
So I think the airline recommendations are after 36 weeks, pregnant women shouldn't fly. And that probably accounts for why obstetric complications are fairly low as a cause for in-flight medical emergencies. But if I remember correctly, that's not something I specifically reviewed, but I kind of remember that from when my wife was pregnant, and I'm pretty sure it's 36 weeks. But don't specifically quote me on that. But that's regulated by the FFA and by the airlines themselves.
And then do you know about how many people die on an airplane each year?
You know, that's a good question. Something I was interested to know as well. And the best I can tell you is that out of those, 750 million passengers that flew in the Peterson et al. Study, just 0.3% of those patients died on an aircraft. The reporting, there's not uniform reporting of medical emergencies, and so I can't tell you an exact number, but most of the different series of data that I reviewed were somewhere around 0.3% in terms of total travelers from in-flight medical emergencies. But another good question.
One question online thus far. The question is, it seems surprising to me that there's not a pulse ox, OX, anything about why in the literature?
Nothing in the literature about why. As I mentioned, they're in the enhanced medical kit. Some airlines do carry a pulse oximeter. And one of the reasons that a glucometer actually isn't included in the standard medical kit is because it requires some degree of calibration and it requires batteries. And so when the FFA created that list, they created a medical kit that essentially could be stocked and then could not be thought about until the drugs and things like that expired. And so I would imagine that potentially the reason for not having a pulse oximeter is very similar to that. That's one of those things that I think you should think about reaching out to your fellow passengers to see if anyone carries those. I know, especially now with COVID, a lot more people have went on Amazon and bought their own personal pulse oximeter. So it's likely that a passenger might have one. And remember, on some airlines do choose to carry pulse oximeters as a part of the enhanced emergency medical kit.
Excellent. Well, thank you very much.
Thank you very much.